Hello and welcome uh, to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Caramelli. I oversee Grand Rounds for our department. So a couple of things before I talk about today's presenter. During the presentation, I encourage you to write in comments or questions into the chat or the Q&A section, and I could go through those at the end. We'll have time for discussing questions at the end. There is a group of us that works on preparing Grand Rounds each week, including Samhara Braha and Mike Walker. We do record and archive our presentations on the department website. Usually they come up the following week. This year's Grand Round series has funding from the Ripley Fund and the Garvey Institute for Brain Health Solutions. Close to the end of the presentation, I'll put a link for a short 4 or 5 question evaluation. I encourage you to complete that. That's helpful for me with planning. So with that, I'll tell you a little bit about today's Grand Rounds presenter. Today's presenter is Dr. Junji Takeshita. Now, on the topic of psychiatric aspects of COVID-19 in the emergency setting, and this is notable because we have sort of a 2-part series happening with neuropsychiatric effects associated with COVID-19, one occurring today, more of the emergency setting, acute phase, and one occurring next month from two local faculty members, Dr. Rebecca Hendrickson and John Oakley, focusing more on research updates. So for today, Dr. Takeshita is professor of psychiatry at the John A. Burns School of Medicine at the University of Hawaii, and is also the associate chair for clinical services. Also directs medical education and patient care services for the consultation liaison psychiatry division there. Additionally, he directs the geriatric psychiatry program and has a clinical interest in emergency psychiatry as well. Notably, this year, Dr. Takeshita is the president-elect, actually now president, as of a couple weeks ago, of the American Association for Emergency Psychiatry. And it's in this setting and in the consultation liaison clinical settings where in recent years, he's developed an interest in the neuropsychiatric effects associated with COVID-19. Very interested to hear about this as it applies to sort of acute phase emergency setting. And I'll stop sharing there and turn it over.
Okay, thank you very much. Let me see if I can screen share and see what this is working. Okay, all right. Thank you very much. Let me just move some things over. Okay, great. So I'm going to be talking about the psychiatric aspects of COVID in the emergency setting. Oops. And I don't have anything to disclose. There's no financial aspects. And the overview is going to be about sort of the direct neurological aspects and the psychiatric aspects. And then what happens to anybody with an existing psychiatric problems with COVID? How do you manage sort of the behavioral symptoms acutely? And then long-term, what happens with COVID? And really, overall, what happens to the general population with COVID, and some of the unknowns really for the future. So, a number of caveats. It's a new illness. That's why it's called COVID-19. If you remember, it's from 2019. There's a lag period of knowledge. And surprisingly, it's still a lot of this is case reports, the so-called in my experience. The peer review that occurred during the initial submissions were not as rigorous as what it has been for usual things. The literature has grown and it's better. And this lit review I did at the end of November, so it's fairly current, but even from November to now, there's been some new developments. The part that makes it so complicated is that this COVID-19 isn't the same thing. The virulence changes, there's new variants, there's new acronyms that keep on coming up. But meanwhile, the clinicians, patients, the community they're getting tired of this, and they're getting tired of dealing with it. Lots of politics about masks, testing, public information. As you know, if you go to any stores now, hardly anybody has a mask now. The people act as if it's gone. Unfortunately, it's not gone now, and the newest variants are actually being transmitted even faster than before. Although, again, it's a different illness than it was previously. So what happens to any kind of pandemic? This has been going on forever, right? The last global one was over 100 years ago, so no one really remembers it, what it was like when, the whole thing with the flu. There's a lot of consequences of being quarantined. There's what happens with the illness indirectly. This racial aspect of illness, the public fears, discrimination, violence, this is not, unfortunately, unique to COVID-19, although, there was a lot of politics that came out because it originated in China, whether it was called an Asian, all this kind of like racial comments about Asians and Asian hate and violence. The case fatality ratio has changed. So the initial COVID that came out in 2019, 2020, people were dying even with some of the treatments involved. Now the case fatality, even without treatment, is much better now. So again, different illness. Still, there's a lot of fears about the illness. And then those who really fear the vaccine, I keep on hearing all kinds of comments from even physicians who make comments about how so-and-so died because they got the vaccination. It wasn't because of X, it was because of the vaccine. So it startles me. I mean, I know physicians who still have not gotten the vaccinations, and they cite all kinds of reasons for this. What happens to the psychiatric parts? Anybody with existing illness gets worse. Lots of demand. There's a lot of grief reactions amongst healthcare staff. There's a lot of work. There's safety issues. If people remember from the beginning, there was a shortage of the PPEs. People had to use the masks for days at a time. People developed PTSD, got pretty depressed. There's a lot of isolation and quarantine, right? The people had to be away from families, friends. They were in a protective bubble. And this happened really all across the country. What happened in the ED service was interesting because we had increased suicide attempts, drug overdoses, partner violence, child abuse, increase in mental health visits. So you would expect that the ED volume would have gone up with the increase in sort of psychiatric aspects. But what happened was actually kind of the opposite. There was an overall reduction in EDs. I remember our ED was pretty empty, but people were coming in for all kinds of psychiatric parts. But even then, the numbers were still somewhat low. And I think people weren't really coming in for anything unless they were really sick. So not surprisingly, things like domestic violence went up. Substance use, overdoses went up. I mean, I think people saw those YouTubes where you saw what people sent out on recycling day, and there was bottles and bottles of beer and wine. And psychiatric patients, not unexpectedly, were more likely to contract COVID-19. So psychiatry had to deal with, what do you do with the COVID-19 positive patients who's acutely manic, acutely psychotic? What do you do when they're now violent? And really for the ED, trying to tease out the neuropsychiatric symptoms was not easy. The financial loss was significant. The hospital staff, many of whom got sick themselves, is an issue. The way that hospitals dealt with the isolation aspects was interesting. Some places had COVID-19 units for psychiatric patients. Other people, they made medical units into a psych unit. I think across the country, there was every every kind of change that was done. One thing that happened that was really good is that this was a time for innovation. Telemedicine just exploded. 5 years ago, we didn't do Zoom for grand rounds. We didn't do Zoom for patients. Now we are. The regulatory aspects just fell by the wayside. And it's hoped that some of these regulations will continue to be there. Although there's a lot of noise about, once COVID-19 dies, what's going to happen to the regulations. Other countries, very similar. Significant decrease in psych emergency visits in Portugal and in Sweden. So it just wasn't just a US thing. So the kind of things that happened were a lot of anxiety, depression, PTSD, kind of feeling helpless, rationing of care. And healthcare workers would call this a moral injury. And what that really talks to is that, we all went into these medical fields to help patients. It wasn't to withhold care. You had to kind of figure out, who was so far gone that, you'd really kind of withdraw care. And this was, I think the last time this kind of thing happened was during the HIV epidemic. When I was a resident, these similar issues came up. A really lack of resources. And what do you do? And again, with COVID, medications were limited, staffing limited, security, conservation of PPE. There just wasn't enough. There was this one study looking at suicides amongst healthcare providers, and they found 26 worldwide, or what they attributed in this case series of COVID-related suicide. But the real problem, though, is that if you look at suicide, is there some sort of, coexisting problem? What is an association with this? Are these people who had some issues to begin with? Is it a cause and effect? It's kind of hard to tell. So again, most of these were case reports where people were afraid of contamination, bad medical care, finance, lockdown, using too much alcohol. Again, not the greatest studies. Were there suicides directly attributable to COVID? There probably was. We'll probably never know how many these actually were. So now shifting gears now from the healthcare person to the patient. Now when the patient comes in, very similar aspects, right? They have a lot of stress, anxiety. They've been under lockdown. They've tried to be vigilant. But for most of our psychiatric patients, they have the added problem of they're poor, they're homeless, and where do they go? So if you're COVID positive and you're homeless, initially a lot of the homeless shelters wouldn't take them. They didn't want to, a spread in theirs. So then there was a rapid shift of creating these COVID positive homeless shelters. As I mentioned before, people weren't coming to the emergency room. So what happens to psychiatric patients? They're much more severe. We often would find COVID-19 as part of just a general workup. And we're still finding that now, that patients are coming in, they look kind of healthy. They may have some minor URI symptoms, and now they're positive. Some of the care delivery issues. I think we mentioned some of these issues already. Just a limit of resources. And again, now I'm not getting yelled at for using masks. Initially, people were giving me a hard time because I changed my mask. It's like, well, you're supposed to wear it. I was told by actually one of the physicians, you're supposed to wear that mask until it's really dirty. And I said, well, really? And you're not supposed to change it every day or two? And they're saying no. So those issues are now gone. So when you see the patients, what we do is really much the same, right, as any patients, COVID or not COVID. But now you had the part of wearing PPE, having to test them. You now had to manage them with all this protective gear. Managing agitation is very different in a COVID positive patient than a non-COVID. Now security has to wear PPEs. How do you take a patient down if you have to, wearing PPE? When do you medicate them? How do you de-escalate them? And really, for the patient, you see a whole bunch of people wearing full PPE. It's a pretty scary experience. Because again, COVID, when it first came out, we were talking about it as a respiratory illness, right? Initially. Then commonly the cognitive stuff became much more apparent, delirium. And then some of the neuroimaging parts came out, but again, a lot of inconsistencies. Obviously, there's some sort of crossing of the blood-brain barrier. What that causes, not really clear. COVID-19 has to cause some sort of breakdown of the blood-brain barrier. Is it cytokines, neuroinflammation causing it? Again, this is really speculation. So we really don't know. And frankly, even for general delirium, the mechanism for why someone becomes confused from a urinary tract infection isn't entirely clear. How is this different from other illnesses? If you look at MERS, the Middle East Respiratory Syndrome, kind of a lot of similarities, where with MERS, there was narcolepsy, seizures, encephalitis, Guillain-Barré, psychiatric disorders, not dissimilar with COVID, where there's some sort of brain injuries and immune dysfunction. And really, a lot of this stuff, the research that's going on this is a current issue. So I'm glad to hear that you'll have a grand rounds on the research aspects, coming up. So about 1 out of 3 with neurological symptoms during the acute phase, and they're finding white matter changes, hypodensities, microhemorrhages, infarct. If you look at this study, this was from 2020. So this is from the early aspects of COVID-19. The unknown is, do the current variants cause this kind of changes? The answer is we don't know, because there's not a whole lot of articles on recent white matter changes, because again, I suspect because people are not presenting in the same way. So people are not doing studies like it was done initially. So the frequency of symptoms, neurological fatigue, myalgia, taste impairment, smell impairment, headaches. So these were the kind of things that were very common and often were listed by the CDC as some of the symptoms of COVID. You hear much less about people now having taste impairment, smell impairment. Stroke was 2%. And amongst the people who are over 60, delirium was about 1/3. And as you know, delirium is an independent risk factor for mortality. It's a very high risk factor. It's really a marker for how sick people are. And people who had any kind of neurologic symptoms had a doubling of mortality. So neurological symptoms, not a good thing. And then what happens to psychiatric illness? Is whatever they had now getting worse? So is their depression getting worse because they're isolated? Are they worse because they're just not coming in? They're taking their medicines, they're not getting their appointments. is there some sort of new illness because of the psychosocial biological aspects? And then the issue about decisional capacity comes up is that, I want to leave the hospital. Can they leave the hospital? The delirium part, again, it's mostly a 2020 issue. It's really severe agitation, restraints, poorly responsive, and then we had QTC problems. People saying, what should I do with these patients? We were doing a lot of this management through telemedicine, where we were using, equipment, phones, because we were supposed to conserve PPE. It ended up in really strange consults where, we'd be calling the patients on their cell phone or on their hospital phone, looking at them through the tiny window, because and all kinds. And I think everybody in the country was doing all kinds of odd things. And then managing these delirious patients, things like antipsychotics, Haldol, olanzapine, quetiapine, using Dex, the alpha receptor agonist, clonidine, the Alpha2, valproate. And then with valproate, we have problems with protein binding, hepatic issues, ammonia, 2C9. And the problem for all this was we didn't have a whole lot of guidelines of what to do. And when I did the lit review, there really wasn't very much. And this article that was in Psychosomatics, and this is when it was still called Psychosomatics, not the current name of the journal. It was experience of the MGH-CL psychiatrist, and this was basically a case series of 19 patients, so 19, not much, and they extrapolated from general delirium management, and they created what they thought was a reasonable stepwise treatment. And I actually have not found much since this period of time. So they talked about step 1, giving melatonin, figuring melatonin's pretty safe, helps with sleep. And they thought maybe give to everybody, this sort of small dose at 6 p.m. Then they thought next appropriate thing would be an alpha-2 agonist. Pretty safe. You're giving Dex, you can give it IV, sublingual, decreases norepi, sympathetic. It doesn't affect respiration. It's kind of expensive, but it's okay. Some cardiac issues, hypertension. Some people tried clonidine, guanfacine. Again, the issue about safety came up. So step 3 became the antipsychotics. And this is where things like Abilify, aripiprazole, potentially benefit, chlorpromazine, maybe sedating, maybe less extrapyramidal symptoms, haloperidol, olanzapine, quetiapine, risperidone, ziprasidone. Again, the entire gamut of antipsychotics of what can be used. Then trazodone, valproate, another step. Trazodone for sleep behavior. Valproate has been used for brain injury patients. Some literature about delirium management and valproate. And then step 5 was things like amantadine, the NMDA receptor antagonist, dopamine agonists. They thought it was pretty well tolerated. Maybe if they're catatonic, giving a stimulant for hypoactive delirium like methylphenidate. That's something that we used to do that among CL psychiatrists many years ago. We probably tend to do it less now, and especially with the epidemic with stimulants. We're probably using it even less than we used to before. Other medications, benzodiazepine, the advantage is that it's useful for sedation, no risks of EPS. As you know, that there's a shortage of intramuscular lorazepam. It can worsen the delirium. Giving injectables, midazolam, I think anesthesia is comfortable with it. Psychiatry is a lot less so. Diazepam is not absorbed well. It's very erratic, so just be cautious. Vitamins, not the standard, but again, it probably isn't going to hurt to give a vitamin. And really from the organ aspects, you look at the the heme, cardiac, hepatic, renal, CNS, pulmonary. So these are all the kind of aspects of COVID. So really medically complicated patients. So one strategy was give antipsychotics for delirium. If there's cardiac issues, maybe consider things like dex, clonidine, valproate, maybe melatonin, and really avoid benzos unless you really have to get the patient to stay in the hospital. And this is, I think, a reasonable thing. And this is the kind of stuff that I do primarily on the CL service. I want to come back to the issue about capacity, which I alluded to earlier. This is an important part because the laws were not exactly clear about this as being an illness that is a public safety. So with any kind of capacity, you have patient autonomy, beneficence, and then the Applebaum-Grisso article, the classic article about communicating a choice, understanding information, appreciate situation, the reason for treatment, do they have capacity? And that alone is a lecture onto itself. And then is it high benefit, high risk, low benefit, this sort of sliding scale of capacity. So what happens to the COVID patient who says, I want to leave the hospital? Is it their capacity that we're looking at? Is it the public health aspects of safety that we're looking at? Is it a risk to the patient, risk to society? So these aspects came over and over again, where initially we were holding patients who were COVID positive due to the public health aspects when we didn't have a so-called lesser restrictive alternative. Now we have, unfortunately, better resources. The consequences of COVID are less severe, so the need to restrict patients who have COVID and a psychiatric illness are a little bit less now than it was previously. Some of the psychological distress, really after COVID, people had a lot of problems, depression, anxiety, especially middle-aged, older people. They found that it did not change much over 12 weeks. So, 3 months later. So that's sort of a change from now acute now to the long-term aspects. So long COVID. So WHO says long COVID is 2 months, symptoms that last for 2 months that cannot be explained by other alternative diagnosis. And the question that's unknown is, how long is going to be long? What's going to be changing with each variant? And this is a lot of these unknown parts. So some of the ethnic differences, they found higher rates of recovery amongst African and South Asian patients in UK study. Why? That's not exactly clear. Is it a biological aspect? Is it something about, help-seeking behavior? And then for this long COVID, what exactly is this? Is it a post-viral syndrome? And they've done some comparison to the so-called myalgic encephalomyelitis, which used to be called chronic fatigue syndrome. So I'm going to use the two interchangeably because I think people are much more familiar with chronic fatigue syndrome. But this is where people would have fatigue, malaise, poor sleep, cognitive deficits, orthostatic intolerance. Very similar symptoms they're finding with COVID. Are we looking at some variant of major depression? Very unclear aspects. People are always trying to find a mechanism. So what might be the mechanism? So this is partially, I think, speculation. They looked at, is there some sort of imbalance in the redox potential? Is there inflammation? Is there some impaired ability to generate ATP? And hopefully your research grand rounds will shed more light on this. Again, in terms of what's been published, relatively little on these topics. What does seem to be happening, though, is that there's growing literature about long COVID and this constellation of symptoms: depression, anxiety, PTSD, sleep problems, fatigue, cognitive deficits. And depression, anxiety being particularly common. Finding female gender, comorbidity, psychiatric health, elevated inflammatory markers. Again, are we looking at some variant of a somatoform disorder? Are we looking at some variant of a mood disorder? Are we looking at persistence? Is it new symptoms? And a fair number of these patients did not have previous anxiety or depression. Some did. Not clear is, will it get better with time? Is it related to how severe the disease was? Is mental illness a predisposition? Is it protective of this? Not entirely clear. So if you look at PTSD, for instance, a long COVID, previous viral outbreaks, people have developed PTSD. And they found that, a quarter had no psychiatric illness. And, is there a difference whether you're an ICU or outpatient severity? They found no difference, at least for COVID. Didn't seem to matter. If they're initially anxious or depressed, it might be predictive. And again, pre-existing psychiatric illness, a factor in most, but not all studies. Gender, there's some mixed data about BMI and the risk of a PTSD and long COVID. So the data really kind of are all over the place here. Insomnia, other symptoms: fatigue, memory impairment, poor concentration, headache, disorientation, OCD symptoms. Lots of variability, but again, huge numbers of people, 50% or greater, with new symptoms that did not exist before COVID. Sleep problems, particularly persistent, delirium, persistent. But the general rule that comes up over and over again is general improvement of symptoms over time. So long COVID, it seems to get better. And this was looking at the database of diagnosis of anxiety, dementia, psychosis, depression, bipolar, or on medications 12 months after hospital discharge. They found no significant differences in post-discharge rates. The caveat was, this was a hospitalized group. There's no cause and effect. We're not sure with each variant what the risks might be. And there's improvement of symptoms with time. And I see a chat here, and maybe I'll do the chats at the end. Okay.
That was just my chat encouraging, reminding people they can write questions. That's all.
Okay, thank you. Yeah. So again, 1 year seems to be fairly magical as to how long it may last for, and the risk getting better. And if you look at the 2-year risk of COVID, they're finding that in this very large study, about 1.5 million patients, most of the mood and anxiety was transient. They returned to baseline in 1 to 2 months, so not a particularly long period of time. People had a lot of, miscellaneous things that they would call it as a brain fog, a cognitive deficits. They had dementia, psychosis, epilepsy at the end of the 2-year period. But again, most of these symptoms eventually improved. And the older patients really with higher rates of death. What was troubling with this study, though, was that with the newer variants of the Omicron, which now is not even the newest variant, they found similar risk. So what was a little bit troubling about some of this data is that this was a Lancet study from 2022, and they found that this might be kind of persisting. So again, it'd be really interesting to hear what's going to happen in the future. So I went through a whole lot of slides, and hopefully I didn't go too quickly on them. The COVID-19 has really affected the psychiatric emergency service in a lot of ways. As we talked about earlier, that initially there was a lot of reduction in visits and people coming in much sicker, a lot of acute and chronic manifestations. And time will only tell what's going to happen. And really, it's not clear whether with long COVID-19 is going to end up becoming a similar illness to chronic fatigue syndrome. I mean, having a pandemic and having the wealth of researchers and data analysis that we have is really unprecedented in human history. That if you look at the flu pandemic in the early 1900s, lots of information, but we did not have the computers back then to tabulate all this information. So this is a global pandemic. We have all kinds of information. This will be enough for the research careers of many, many people across the world. And hopefully we'll come out of this with much better information for the next pandemic, which will invariably come. And when that's going to be, I hope it's way in the future, but as you know, we will not know. So with that, I believe this is my last slide, and I will stop screen sharing and open up for any kind of questions or comments.
All right, yeah, we do have time for questions. I want to encourage people to write in with any questions, comments. Well, one thing that comes to mind, just to maybe start off questions, is in the last, let's say, 6 months, have you seen a shift in consultations to the emergency department? Is it more like usual, or how things were previously? Is the distribution of problems different? Is the demand higher? What have you observed in recent months?
It's more like usual. It's the COVID patients we're finding, it's really an incidental finding, and that ones who are positive, they're not that sick. And I've also noticed that the change in the caregivers too, amongst the healthcare people. People don't get so excited about it anymore. I remember the first patient I had to see with COVID, the hospice was showing me how she did it, double gloving, wearing shoe covers, all the stuff. People don't do that anymore. And I think it's sort of, I don't want to say back to usual, but it feels almost back to usual.
And yeah, are there updates about that you're aware of efficacy of Alpha2 agonists or other adrenergic modulators for COVID delirium versus other delirium? It's an interesting area.
Yeah, that's a great question. I did not find anything on this. It was sort of in my experience from the Mass General group. I think this is so new. We don't have a head-to-head studies. We don't have anything. And now at least for on our CL service, I would be curious to see how things are on your CL service. The very sick COVID patients that are getting delirious and agitated, much less now. It just seems like an illness, like something else.
So your approach is more like a delirium that you might see generally, not
Yes,
not approaching it. I see.
that is what we're kind of beginning to manage with. That it has not become any like it's not becoming as unique as it was initially. Where I remember in the early days, patients were agitated. We would give them our usual antipsychotics. It didn't seem to do very much. We were doing all kinds of other stuff. We were giving, valproate. We're using the Alpha2 drugs. So things are better now.
And another question came in regarding use of fluvoxamine. Clearly, a lot of excitement earlier on, which seems to have decreased some.
Yeah.
Can you comment on that, or maybe decrease more than some?
Great, that's a great question, because we saw those studies as well, and we thought fluvoxamine, it's a pretty cheap medications, pretty low risk. Why don't we give it to everybody? We thought about it. We did not. I don't know whether you guys had an experience giving it to patients.
I would need to ask more broadly. Perhaps somebody could comment on that. But it sounds like it's not something that you're using in the acute phase.
We were not. We thought about it. We thought about it, and then we thought, okay, this is low. If you look in terms of sort of the the risk issue, it's low cost, low risk, potential benefit. And we were actually talking to our hospitalist colleagues about this, and they weren't as impressed. So
yeah, I remember the original trial that came out about that. It was a unusual recruitment strategy. I think that was also very notable early on in COVID-19. Other comments? I mean, I guess, have you seen or what's the status of research about new you commented on worsening of chronic psychiatric disorders. What about new problems, new mania, new psychosis attributable to COVID-19? Is this something you've seen? Is what's in the literature?
Yeah, and that's again the great unknown, is how many of these people are people who just had illness, never diagnosed, and now have psychiatric illness? How many of these people are actually had a history of and now are worse? And then how many people are a direct, cause and effect? And I think that's the part, is that I think we're going to have probably a large number of association studies. And although the media always likes to call association studies a cause and effect, they're associations. So.
Well, I'd like to encourage any other participants to write in with questions or comments. I think in the and questions related to acute phase symptomatic treatment and so on. I guess as we're going through ideas about presentation in the emergency department or transfer elsewhere, it sounds like the service maybe is more typical in the emergency department as far as maybe number of patients. Are the types of questions similar, the types of problems that you're seeing?
It seems a lot more similar now. I think the biggest problem, I think, in the early COVID days was the patient who came in acutely manic or psychotic, or some sort of danger was present. And really management of these patients. How do you manage them? Do you keep them in the emergency room? Do you send them to a medical floor with psych backup? Do you create your own psychiatric unit? And again, talking to other CL psychiatrists and other psychiatrists across the country, people did every combination of that. And we actually had talked about starting our making one of our units, our psych units, a COVID psych unit, but that was very unpopular amongst nursing. Yeah.
I'm wondering about your advocacy role now as president of the Association of Emergency Psychiatry. What is this a focus? Is there like a COVID-19 subcommittee? Is this a focus of the association? What is the direction? What's the vision that you see with the association and its role here? Yeah.
Thank you very much. Yeah, because I'd like to talk a little bit about the emergency psychiatry group and what this is, because I think this is a group that, you know, a lot of people may not be aware of. We're the only emergency psychiatry organization in US. It's a multidisciplinary group. It includes emergency medicine people, emergency psychiatrists. We have non-physicians in our group. We have some people who are social workers. We have people who are advanced practice nurses, nurse practitioners. We're a very heterogeneous group. There's no one looking at COVID-19 per se. It's that we all had to deal with COVID. So the authors of a number of those articles are members of this organization, and they're ER psychiatrists and ER medicine people. And it's really more of a kind of an observational as to what to do about these kinds of patients. I think in the long term, you know, for the emergency room, this is like, how do you deal with a major sort of pandemic crisis? And this is what this thing showed. So I think as an organization, I think we need to kind of look upon when the next pandemic comes, how do we deal with emergency psychiatric patients? And that's something I think we really need to figure out, probably for the better.
A couple of questions came in. Thank you for commenting on that and for association, just the practice of emergency psychiatry in general. But someone wrote in if you could comment on a particularly notable ethical circumstance about decisional capacity that you saw. What were some of the tensions, especially if it was related to skepticism about COVID-19?
Right. So lots of sort of ethical issues came up. Multiple, for instance, the patient who comes in who does not want to get vaccinated, right? That comes up over and over again. Or the physician, healthcare provider who doesn't want to get vaccinated. And a lot of the hospital mandates that occurred, and the coercion or persuasion that comes up. The issue about capacity comes up of, you know, somebody who lives by themselves, then, or having, you know, at least a caregiver and has a quarantine space. That was pretty straightforward. Most of our patients did not have any of those. They were homeless, now COVID positive, and they weren't going to sit quietly at the corner of the park. What do you do with these people? And really, from the standpoint of being the healthcare side, it was a very demoralizing time.
Maybe similar ethical challenges under new clinical conditions, new similar circumstances, weighing autonomy versus other needs. Yeah.
Yes. Right. And again, the writer, it was not quite like tuberculosis, where you had specific mandates for quarantine. So you couldn't quite use a tuberculosis example.
I see. Another question came in. This is interesting about, I mean, this relates a lot of things. Changes in sleep patterns, circadian structure, disrupted during delirium.
Right.
Of course, there were thoughts about this being disrupted or altered early in COVID, even without delirium, though. It's interesting. Did you observe this? Did you see it clinically?
Yes.
What about now? Yeah.
Yeah, we saw it early. Now we don't. I think the patients are less delirious. But you're right, even the non-delirious patient early on, I think we saw it. We saw it clinically. And it seems to be less of an issue now. But again, that's more of, as they say, in my opinion or in my observation. So I haven't seen a lot of research studies on this.
And relatedly, I guess talking about sleep or sleep architecture, someone inquired about use of modafinil for any symptomatic relief. Have you tried this early on?
I have not. That's actually a great comment about modafinil, since it's the so-called non-stimulant stimulant drug. Whether this might be a preferable option to giving methylphenidate. That's actually and I'm glad to see that in the residence journal. I've not seen this paper, so I will have to find this paper.
Yeah, interesting. Yeah. Well, I want to say we do have 6 or 7 minutes left. If there are other questions that people have, yeah. And as far any other questions, I'll just give a moment. What about adverse effects with medications? Did you see higher occurrence, more frequent adverse effects, common or uncommon in the context of treatment during COVID-19?
Yeah. It seemed that what we saw early on was people just not responding. That was what we saw a lot of. I mean, I remember the residents would complain saying that, the usual things that we give our delirious patients, they're just not working. And what do we do when they're not working? And we tried all kinds of stuff that, beyond the usual antipsychotics. The sort of the usual mantra in CL is give antipsychotics for delirium, avoid benzos, take care of the underlying medical problems, right? That's sort of the mantra. And the medical team was trying to take care of the medical problems, but they weren't making much headway. Antipsychotics weren't not that effective. We ended up using a fair amount of valproate earlier. Why? Because they got a little bit knocked out from it, became less agitated. Was it really treating anything? I don't really think so. But we did all kinds of things in the beginning. And I think that's what Mass General was doing as well. They were doing a lot. I think everybody across the country was doing things, but not in a systematic way.
And let's say, just to make a hypothetical here, someone has maybe existing diagnosis of depression. Depression you're observing seems to be worse in the emergency department. Coincidentally, COVID-19 is present. Would you proceed as normal with next steps in depression treatment? Would something need to be modified? Yeah.
Yeah. So we would treat major depression in the usual way, being cognizant of maybe, any kind of confounding medical issues, issues about cytochrome and others. We would do that. There was one group, by the way, that was a serious problem, where the patients who were getting electroconvulsive treatment on an elective basis. That was actually a fairly large group of people where all the elective surgeries, elective treatments were stopped. So there's a group of patients who had been stabilized on ECT and did well now who are not getting ECT. That was a problem because now the medicines that didn't work before we had to use again as a sort of a stopgap measure. And so that was a problem. I don't know what other people did, but I think in most hospitals across the country, anything elective was canceled, especially in the beginning part.
Yeah, I think ECT was halted widely. Yeah. Well, I guess I'd encourage any final questions or comments here towards the end. And if there aren't any, I guess I'll pose one question about catatonia. You mentioned it during your presentation. And was catatonia different when you saw it in COVID-19?
Yeah.
I mean, it can be different every day in different people, but
Yeah.
did you notice consistent differences in COVID-19 related catatonia versus others?
It did not seem different. The problem I think with catatonia always is that what do you do now? Because the treatment we often give to these patients are benzodiazepines. And if they have a component of delirium, it'll make that worse. On the other hand, if you give an antipsychotic, you could potentially make the catatonia worse. So now, what do you do? I think that conundrum wasn't much different for the COVID patients compared with the non-COVID patients. But that's something that I think we always wrestle with on the CL service is how do you manage the catatonic patients? And frankly, the floor doesn't really care about catatonia until they stop eating. And then they care about it. So we often get consults on these patients quite late.
Yeah, I was just thinking through if there were different, maybe different motor findings but it sounds like not a consistent pattern.
It was nothing consistent
yeah,
that we saw. And I think that was a part of it. And again, if you look at beginning to now, it is not common now for us to get those kinds of consults that we used to get initially. We used to be wearing the PPEs all day long, seeing patients after patients with, acute psychiatric illness like mania versus the delirious, agitated patients. But again, it's become much less, fortunately.
Given that there hasn't been another question that's come in, I guess I'll pose one about training. You mentioned about trainees. Here it's been 3 years, and you've trained a lot of people in emergency psychiatry and CL psychiatry. And what are some major adaptations? What worked really well for training?
That's a great question, and is that for the trainees, it was a tough experience. Medical, there's a group of medical students who basically got all their education through videos and books. We're now beginning to see them. They seem to be a little bit more hesitant clinically because I think they had less hospital work. Some of the trainees were not allowed to see COVID patients. At one point, they had this absurd rule at our medical school where the third-year medical student could not go to the emergency room because they thought the emergency room was had too much COVID. Whereas a fourth-year medical student somehow was okay to go. But even the fourth-year medical students could go there, but were not allowed to take care of a known COVID patient. So they're trying to stratify this risk. Third year, nothing. Fourth year, can go but not do anything. The intern could do whatever. So the intern and upper level residents could do whatever they needed to do whatever. What was good about it, I think, for the trainees here was that they were not, mandated to do other tasks. I know people at other hospitals who got roped into doing all kinds of tasks, like being a respiratory tech, but we did not have experience.
Well, here we are just at 1 o'clock, and Dr. Takashita, I would like to thank you again for presenting today in Grand Rounds to hear about these emergency, not only presentation, but the systems issues as well that went into COVID-19 in the emergency setting. And I appreciate your presenting on this clinical update. And like I mentioned early on, we'll have a second part of sort of neuropsychiatric aspects of COVID-19 next month. And with that, we'll end Grand Rounds for today. So thank you.
All right. Thank you. Thank you very much for having me.
I appreciate it. Take care.
Bye-bye now.
Bye.